In this video, we are going to take a look at and discuss some of the things we need to think about when we run machine learning models on healthcare data. And I'm going to do this in the context of one of my old studies, which focused on predicting healthcare costs. So the study, the algorithmic predictions of healthcare costs, was a 2-year collaboration when I was a PhD student at MIT. So it was a collaboration between MIT and then D2 Hawkeye. That was a startup out in Massachusetts that then got acquired. And we were a team of 8 working on this over 2 years, just to give you a sense for the scope. But our computers were slower back in the day, so things took a little bit longer to run. So why were we motivated to take on this study? So the initial goal was to gain some insight into the rising healthcare costs. So that's not a new story about the continuously rising healthcare costs, and we wanted to gain some valuable insight. We also wanted to contribute to medical intervention, so think about how can we identify patients who are at risk of declining health, and declining health is usually reflected in higher healthcare costs. So we're using healthcare cost as a proxy for declining health. And we are going to learn all about how the limitations of that in our last module in this course. So the study is based on claims data. So claims data get generated when hospitals and other healthcare providers send their claims to the insurance companies or the payers to receive reimbursement for their services. So that's the data that we capture. So similar to many other healthcare data, and maybe especially in claims, it's all based on codes. So whether it's diagnosis or procedures or drugs, everything has a code. So the first thing to think about when you get your hands on interesting healthcare data is try to translate those codes into English so that we can have a meaningful conversation about the data. So if we, for example, look at that first claim, the claim type tells me that it's a dentistry claim from a particular provider. Then in the original raw data, we just had the diagnosis code DT0238, but we translated that into a dental disease. And then we had, for example, a procedure code, this DT007, and that stands for anesthesia, and then we have a service date. So what you might look at this and say, okay, what are these codes, DT0238 and DT007? This doesn't sound familiar to me. So one thing that we had done prior to creating this overview of this data is actually painfully going through all of the ICD-9 codes and group them together into diagnosis groups. So that's what you see there, this DT0238 in that first row. It's really focused on getting all of the codes together from the ICD-9 that affect or describe dental disease. So I think often our codes, so this highlights one of the important things that we need to do when we work with healthcare data, and that's actually taking a critical eye to the coding systems being used and ask ourselves, do I need to group my codes together to make them more meaningful? And that's what we did here. So this isn't even the raw data. This has already been, we have grouped all the codes together. We actually translated them into English. But still, when I look at this, which is, quite far from the raw claims data, it doesn't really give me a sense for, okay, what can I say about the patient? So I would encourage you, every time you get your hands on a new data source, is just to simply recreate the story of a patient to get a better sense for, okay, what does a patient look like in my data? And then you can build from there. So that's what I did here. So here I have drawn up a story about a random patient, happens to be a 45-year-old single male in Massachusetts, might not be single, but he didn't have any dependents in the data set. And his story starts in 2003 in December, where he goes to the outpatient visit and he complaining of his shoulder and gets an X-ray. and some prescriptions. And what is interesting, especially looking at the rear view mirror, is that this patient immediately gets Vicodin and actually has a refill a week later after his visit. Right before New Year's, he visits the office again, and this time they drain the joint. And again, we see very strong painkillers being prescribed. Followed by an office visit just after the new year, and then even more pain relievers. There's also antibacterial medication, maybe to fight a potential infection in the joint. We don't know, but we can hypothesize. And even more pain relievers. And then interestingly, in the middle of January, there's a prescription for an anxiety drug. So we know that this is a refill because it didn't immediately follow an office visit. So this is a person that has been suffering from anxiety. And then the story continues, and we can see increasingly these pain levers being refilled over and over again. And if we follow his story all the way through March, it looks unresolved. So all of this to kind of show you that, okay, I had this raw claims data, but now I have a better sense for what might a patient look like in my data. How can I model each patient journey, etc. So what we did, we thought about, okay, thinking about future healthcare costs, we are going to try to predict next year's healthcare costs. So then we could start to summarize, think about each patient and how do we summarize all of their claims prior to kind of the start of the prediction period. So for each member, we created a very long vector where we try to summarize the patient journey over the past 2 years. So we grouped, like I talked about earlier, all the different ICD-9 codes into diagnostic groups. We did the same for procedures and for the prescriptions. And then for each diagnosis, procedure, and drug group, we simply counted. How many times did we see, for example, the code for diabetes? Or how many times did we see the code for COPD, as an example? So we captured all of the diagnosis procedures and drugs with about 600 variables. And then what we also did in collaborations with our physicians was to build in business rules. So physicians, clinicians really know the medical literature. And from that literature, we try to capture what are especially risky combinations of codes. So for example, if you have a cardiac condition and you're above 50, or you're a diabetic and you're not on any diabetes medicine, or you have a cardiac disease and you're obese, that carries an additional risk, right? So we try to capture all of that and many more with over 250 risk rules that we then just implemented with logic. We also try to capture what are kind of the key drivers of the costs. So we noted the 2 chronic conditions that had the highest claims for each patient. So is it your diabetes that's driving your costs, or is it the obesity, the asthma, the cardiac condition, etc.? Then we recorded gender and age because these were the 2 demographic factors that we had access to. And then in addition to all of these variables, we had very detailed information about cost, because if there's one thing that you can trust in claims data is actually the cost, because providers are trying to get reimbursed. And then in addition to kind of simply summarizing, okay, what is the total cost in the previous period, what is the cost in each of the last 12 months, we also thought about patients' journeys and how they might be spending their healthcare dollar might be reflective of their risk. And this is not something that we came up with just by sitting and hypothesizing, oh, what might be good data features. We actually ran some initial models, and then we looked at like, where did we go really wrong? Meaning, for which patient did we predict really high cost, but they turned out to be very low cost patients, and the reverse. And what we found was that the way they spend their cost dollar is super important. And we captured that by a couple of variables. One of those variables is called acute. So I'm going to explain that with this graph. So here we have the cost of two members. So member A is with the zeros, and the triangle member or corresponds to member B. And if we first look at the data points for the zero here, we can see it lies right around 0 in the first month, second month, and then it rises in the third month, go down again, up again, down again, up again, and then down again. So over the last 12 months of the observation period, meaning the last 12 months before the prediction period where we're going to try to predict the healthcare cost, they were continuously spending some healthcare dollars. So this pattern is representative of what we called a chronic spending pattern. And then for each patient, we captured whether their spending pattern was reflective of a chronic spending pattern. And in contrast, member B, we can see there's no cost in the first 3 months, then it really spikes, it comes fast down again, and is then 0. So this pattern we call an acute pattern. So this patient might be spending a lot of healthcare dollars, but they might carry a very low forward risk. So we captured this into our data, and this actually helped predicting some of those cases where we did terrible with our initial models. But adding this information about the patterns in the way patients are spending their healthcare dollars really help. So I will stop here, and then a little later in the course we will revisit this case study and talk about the actual prediction.